This episode of Common Health is brought to you by Reg Lantern. Reg Lantern is a straightforward and easily understandable software platform built to assist community health centers in staying compliant so they can focus on serving their patients rather than paperwork. For health centers that are serious about achieving, managing, and maintaining compliance, Reg Lantern provides a comprehensive approach and is an affordable and valuable solution. Reg Lantern can help your health center. Contact them today at reglantern.com. That's REG, as in regulations, lantern.com. For special discounts, mention that you heard about Reg Lantern on the Common Health podcast.
Hello, and welcome to Common Health from the Virginia Community Healthcare Association, or VCHA, or what we're also known as is VACHA. I'm Tracy Douglas, VACHA's Chief Executive Officer. On Common Health, we're amplifying the voices of community health, both those who give care and those who need it. And we come to you again today on Common Health to talk to you about the 340B drug pricing program. And I know many of you do not know what that is. You might have heard about it. Some of you may be in the federally qualified health center, community health center world, or you may work for a hospital that's a designated 340B entity. And that is exactly why we are bringing you this program today, because we want you listeners to get in the know, right? We did this show for the very reason of helping that common voice come to the surface. And we really feel that the 340B drug program is a way that we can actually bring a topic that really should, we should all care about this 340B drug program, because it really does impact so many of us out here, not just in the Commonwealth of Virginia. And today, listeners, we've got somebody who is, oh my God, when I need to know anything about 340B, I call this lady. Okay, she is the queen of the know as far as understanding 340B. Her name is Colleen Meiman. She is a national policy advisor to the state and regional associations of community health centers, like the Virginia Community Healthcare Association, the program that brings you this podcast. Colleen is the national policy advisor for the 52 state and regional associations of community health centers throughout the United States, often called primary care associations. Listeners, you've heard me talk about that. Prior to starting her role in January of 2020, Colleen has spent 6 years with the National Association of Community Health Centers as the Director of Regulatory Affairs and Senior Policy Advisor. She also spent more than 2 decades in the federal government, including in the Health and Human Services Secretary's Office, in the U.S. Senate, and in numerous other positions within HRSA. Her expertise is in the regulatory, administrative, and financing aspects of federal programs such as 340B, Medicaid, Medicare, Section 330 of the Public Health Service Act, and the ACA, and how they impact community health centers and their medically underserved patients. Welcome, Colleen. Thank you for joining us today.
I am very happy to be here, and I really need to update my bio, because whenever I hear that, it sounds like, wow, that woman can't keep a job. She's been here, she's been there. It made more sense at the time. Can I just say that? All the moves made sense at the time.
But Colleen, this is exactly why we have you on here, because of all that you have done, okay? You bring so much expertise to the table, and that's why we have you. And we are very, very thrilled to have someone like you on our show. But before we get into the nitty-gritty of 340B for our listeners, I want to get some advice from you. If you would, given speaking of your career, right? If you would give someone wanting to pursue a career that was very similar to yours, that being in policy and regulatory affairs, what would you say to some of our listeners who are thinking about that kind of a career?
I think I would say 2 things. First, I would say find an issue, a policy area that really speaks to your your soul, for lack of a better word, to your personal mission. Because there are days that I think, it can be really hard work and it can be demanding. But in this field, it is such an incredibly important purpose that we serve, ensuring access to healthcare for everybody who lives in the United States. And I work with such amazingly wonderful, dedicated, good-hearted people that sustains me through all sorts of situations that otherwise would be kind of challenging. So find something that you feel very strongly about personally. The second thing I would say is don't hesitate to go out and get a lot of different perspectives on issues. I mean, as much as I joke about not being able to keep a job, it's helpful for me that I've seen federal health policy programs from the policy side from the programmatic side of administering them, from the political side on the Hill, and also from the trade association side, working directly for the providers. So I think that makes me more valuable than I would be if I had only ever worked on these issues looking for one particular angle. So I'd recommend that also.
Awesome. All right, so let's get into this nitty-gritty stuff. Let's talk about 340B. Again, I know it's an area that you don't hear people talk about in the coffee shops, right? But it is so important, right? It is so important for all of us to really know what this 340B program, because it, in some form or fashion, it could end up coming into our life, right? So with that, can you please explain to our listeners, what is the 340B program?
Well, the first thing is the 340B program has to be the worst name for a program in history. It's named for Section 340B of the Public Health Service Act. And the program wasn't even given a name at the time. That's why we just have to call it like where you find it, like you call a 403B or a 401K sort of thing. It is a program that says to drug manufacturers, hey, drug manufacturers, if you want to participate in Medicare and Medicaid, in other words, if you want Medicare and Medicaid to pay for your drugs, one of the things you have to do is agree that when you sell drugs to safety net providers, and by safety net providers, I mean the providers who will care for anybody who shows up regardless of ability to pay. And community health centers, also known as FQHCs, are really the backbone of the national safety net. When it comes to primary care. Anyway, so the 340B statute says manufacturers, to get into, to participate in Medicare and Medicaid, you must give a discount to safety net providers when they purchase these drugs, the same drugs. The idea was that safety net providers are generally running on really, really tight margins. I joke that a lot of health centers run on bubble gum and shoestring to keep things together. And we are small, community-based organizations. We aren't these giant organizations, big, for-profit hospital systems that can go out to a drug manufacturer, like let's just say Eli Lilly, and negotiate really good prices. We're too small. We don't have that market power. And so what 340B says is, hey, you have to give discounts to these little guys who are really serving the public interest in the same way. I mean, they don't say it flat out, but similar to the discounts that you can get when you're a larger organization and can negotiate. But then the important thing to know is what happens with those discounts. So health centers end up spending less money for pharmaceuticals to begin with. And just to be clear, it's not just health centers. There's Ryan White clinics and certain disproportionate share hospitals also participate in 340B. But I work for health centers, so that tends to be the lens I look at this program through. So let's just say a health center, they pay less for these drugs than they would have if they were just having to buy them on their own. And that enables them to do two key things. The first thing they do is it enables them to be able to afford to offer pharmacy services to their medically underserved patients. Okay? Because we're paying less, if we dispense that drug to an uninsured patient who often can't even afford the price that we paid for it with the 340B discount, well, then at least we're losing less money. It makes it a lot more affordable. for us to be able to provide those drugs. In fact, before 340B, almost no health centers provided pharmaceuticals because they were just too expensive. So that's the first thing 340B does. It enables us to make drugs affordable for low-income, underserved populations. The second thing it does is, like a lot of providers, it ensures that there's a difference between what we paid for the drug and the amount that an insurance company will reimburse us. Okay, as I said, a lot of large providers can get that spread automatically because they can negotiate those discounts. Well, this gives us that difference. So there's a difference between what we pay and what the insurance company pays. Well, then those savings that comes in, we use them to expand access to care for, in the case of health centers, we serve underserved populations. So 340B savings can be used to do things like support behavioral health services, support dental services. They've supported a lot of COVID services in the early days, because by freeing up funding, then we have the funding available to use for all of these other activities that otherwise would not be funded and would not be provided.
So when you say support all of these other activities, and I think this is going to bleed into this next question that I want to ask you. But when you say support other activities, what does that support look like? Can you speak to what some of that support looks like?
Mm-hmm. Absolutely. But the first thing I would say is, obviously, as we mentioned, it supports making drugs affordable for low-income patients. But what the support looks like then outside of the pharmaceutical space really varies by the 340B provider. And that is an enormous benefit of the program, because so often the funding that safety net providers get is very targeted. You must use this for behavioral health integration for pregnant women, those sorts of things. This is funding that, in the case of the community health center, they're run by boards that the majority of the members are their own patients. So the patients can look around the health center and look around the patients that they serve, the board can, and say, what we need most in our community is this, and that's where we're going to invest our savings. So in one community, a lot of the funding may go into, let's say, behavioral health. I know a lot of health centers where over half of the cost of running their behavioral health services is funded by 340B. Sometimes it's as high as 80%. And behavioral health is not just mental health care, it's also substance use disorder. Because, so many of our patients come to us either uninsured or with deductibles that are so high that they can't pay them. And so these funds enable us to support those services that the patients can't pay for. Another popular one, but it depends on the community, is dental services, particularly for adults. Even in states that have implemented the ACA Medicaid expansion, very often coverage for adult dental services is limited. And, adults' dental services are so important in terms of pain control, in terms of people's economic well-being and their ability to maintain a job, all of those purposes, quality of life. So very often 340B savings are used to support to make those services affordable for patients. I know a lot of health centers who have used 340B savings to purchase mobile vans. And so sometimes, let's say it's a health center in a rural area, they will take those mobile vans and send them out on a weekly or monthly, depends on the community basis, and provide services where people are so that people don't have to come in all the way into the provider and find transportation and get the time off work and everything. They can get services where they are. Another common example is school-based health centers. I think hopefully, probably our listeners are very well aware of the mental health crisis that so many children are facing coming out of the COVID pandemic. Well, health centers use 340B funds often to set up services right in the school, so that the patient can, the student can come down during lunch, during their free period, in the middle of class if they need to, and get anything from, a checkup to a dental sealant program to a mental health service. So it varies health center to health center. But what I can tell you is the services are used, the 340B savings are used to fund those services that expand access, that are chosen by the board as being the areas of greatest need for the community. So that's like, for instance, in the beginning of the COVID pandemic, 340B funding was what was used to set up a lot of, remember the drive-through clinics, the vaccine clinics?
Yep.
A lot of it was even pulled at that point from other activities because we needed funds and it was there. And that's what 340B enabled us to turn on a dime and provide those services. It also enabled us to turn on a dime and set up telehealth within a couple weeks. It was amazing. Prior to the COVID, I forget the exact percentage, but only a very small percent of health centers were provided telehealth. But suddenly they had no choice, and 340B savings enabled them to go out and buy the equipment that they needed to make telehealth a reality.
What have been some of your biggest concerns, Colleen, around information and the education on 340B?
I used to joke that, I would say that there's so much misinformation out there about the program now, and there is also so much well-intentioned misunderstandings around the program. I said that, 5 years ago when I would talk to people on the Hill about 340B, the issue was largely that they didn't know anything about it. The issue now is much more that people think they know something about the program, but what they know is not the complete picture. It's not necessarily an accurate picture. For example, there was a story in the New York Times about a hospital in Richmond, Virginia, a couple months ago now, that there's an important distinction in the 340B world. Almost 90% of the program is hospitals, and hospitals are not required to invest the savings into services that expand access to underserved populations. I'm not saying that none of them do. I'm sure there are plenty of hospitals out there that do that. But health centers, on the other hand, and Ryan White grantees and STD clinics, we are all required by our federal grants to make sure those savings go into protecting, to expanding services for underserved populations. Well, that New York Times article about a hospital that, according to the author, was not using its 340B savings to expand access for underserved populations. We're dealing with a lot of health centers being painted with the same brush. People saying, oh, well, we read an article about one hospital that wasn't doing it, and so it must be the same for every 340B provider. My response back to that is, I cannot speak to the hospitals. I don't work with hospitals. I'm not knowledgeable about them. But I can tell you that health centers, by law and by regulation, not to mention by mission, are investing every penny back into expanding access.
Okay. And you talk about how you gave us great examples on how they've reinvested back into the community health center and their services, and ultimately into the communities that they serve by way of those services that they offer. And in our world, in our community health center world, we deal with a lot of acronyms and all that, Colleen.
Oh, yeah.
And so for the purposes of helping our listeners continue to understand this program, right? Can you, speak to how the 340B is made up in the community health center? Meaning, as when somebody hears pharmaceutical drugs and prescriptions, the first thing they hear about, oh, I go to CVS to get my So can you just talk to our listeners a little bit about what does contract pharmacies mean? What does pickpocketing mean? What does all of that gets tied to this 340B pharmacy program.
Absolutely. Yeah, no, there's a lot of kind of inside baseball terms that float around with this program. And I heard somebody introduce a new one last week. And I was like, no, don't go there. Our heads are all going to explode. So,
right.
Yeah. So in terms of pharmacies, where the patient actually goes and picks up the drug that was purchased under 340B with this discount, there's two general models that health centers follow and other 340B providers follow, okay? The ideal situation, the situation every health center wants to have, is what we call an in-house pharmacy. And that means a pharmacy that is actually owned by the health center. It doesn't physically actually have to be in the same building as, say, the care clinic, but it is owned by the health center. And in this case, it's just the patient, in an ideal situation, goes to see the provider, and on their way out the door, they walk by the pharmacy and pick up their prescription. And it's very easy to have clinical pharmacy involved, coordinate care, etc. It's the model everybody wants, and wants to make work. The reality is that often doesn't work for all health centers and all patients. Okay, because patients can't get to the pharmacy at the times that the building is open to pick up their prescriptions, or the service area is so broad that it's a real hike for people to be able to get to the pharmacy, even if they can get there at the right hours. Okay, so because of that, health centers and other 340B providers can contract with other pharmacies in their community. And that can be a big chain pharmacy like a Walgreens or a CVS. It can also be a little community pharmacy down the street. I just was visiting with one of those in Kansas the other day. And the idea is that by having these other pharmacies do the act of dispensing the drugs, giving the drugs to the patient on behalf of the health center, it does two major things. It enables the patients to be able to get the drugs in a location that works better for them, and generally with better time options. There's a lot of security around running a pharmacy. A health center can't run a 24-hour pharmacy generally. They often can't have it open on days that the health center is closed, or on weekends when the health center is closed. So it really expands access in terms of location and in terms of hours. I was talking to a health center recently in northern Arizona, and their service area spans the entire state of Arizona, which I learned driving even above the speed limit takes 8 hours to cross the state of Arizona. And so they said, we can't afford to support pharmacies in all of our clinics because the rural areas and pharmacies are hard to keep open. Even private pharmacies that have nothing to do with 340B are struggling to stay open nowadays. So they're like, we can't have pharmacies all over our service area. We can't afford that. Okay, we don't have the bandwidth for that. So let's say we just had one in-house pharmacy in the middle of our service area. Well, if a patient wanted to come and pick up their drugs and they live at the extremes, it's 4 hours to go there and pick it up and 4 hours to drive back. It's a little crazy. So contract pharmacies allow us to extend the reach in terms of both location and then hours. Another term you may hear a lot is pickpocketing, or other terms for the same practice are discriminatory contracting, discriminatory pricing, etc. And this goes back to basically a fundamental flaw from my perspective, and speaking as a former Fed here, in how the 340B statute was written. So Congress said, okay, health centers, we're going to allow you to get a discount on these drugs. And then when you provide a drug to a patient with insurance, there's going to be some savings. Just a simple example I use all the time is, let's say the regular price for a drug, the sticker price is $100, and 340B enables us to, as a health center, to buy it at $70. But the insurance company still reimburse at $100. So that $30 difference what's supposed to be used to fund our dental clinics, our school-based care clinics, our COVID pop-up clinics, all that sort of stuff. Well, a few years back, some outside groups, such as pharmaceutical benefit managers and insurers, but they're not the only ones, realized that Congress gave health centers the ability to get 340B savings, but they didn't give us the ability to keep them. And what I mean by that is these outside payers have found creative ways to essentially take the savings away from the health centers. This has been a practice really only it's really gone mainstream maybe in the last 5 to 6 years, 6 to 7 years maybe. But increasingly, health centers have to turn those savings over to a payer. There's many ways to do this, but the simplest example is I'm thinking of one large PBM nationwide who says, okay, when we reimburse for a drug, we reimburse 100% of, I think it's the wholesale acquisition cost, except if that drug was purchased under 340B, in which case we know that you got a discount. And so we're only going to pay you 69%, 31% less. We're going to pay you 31% less for the exact same drug dispensed to the same patient on the same day under the same plan, just because it was 340B. What they have effectively done there is transferred that $30 in savings from the underserved community and the health center to the bottom line of the insurer or the PBM. Mm-hmm. And the problem is that that's not a victimless event, because that $30 is what is supporting so many of the health centers' activities for underserved populations. And so those actions are undermining the safety net. And because of that, we now have 22 states who have passed laws banning this type of discrimination or pickpocketing to the extent that states are able to do so, including the state of Virginia. Yep. Is one of those states. We also have a law a bill in the House of Representatives that was introduced by Representative Abigail Spanberger of Virginia. Thank you, Virginia. Yeah. That would be a national bill to prevent these types of pickpocketing or discriminatory practices. The idea is Congress meant for these savings to go to safety net providers to expand services for underserved populations. And the law would make sure that they actually stay where they were meant to go, and they're not picked off by these outside for-profit groups.
Right. And listeners, I want everybody to know and understand when Colleen refers, and even some of our other guests have been on in the past, have referred to many of community health centers' patients as underserved. I want you to understand something, and we've talked about this, listeners, is that underserved are people who live in the rural communities, right? Mm-hmm. If you live in an urban setting, you have access to public transportation. Many people in the rural communities within our state, as well as throughout the United States, struggle with transportation. And they struggle with being able to get access to healthcare services and their pharmacy drugs. And many of the individuals that do live in our rural communities, their incomes are very, very different than what you might see in some of our urban cities. So I want everybody to understand that this is a program that really benefits so many different individuals within not just the Commonwealth of Virginia, but many communities out there. And so I say that to say, to my next question to Colleen, when many of us hear about federal programs and making decisions whether a certain particular federal program should exist, why should the 340B program exist? And does that require tax dollars to be supported?
The 340B program, the two parts there, should exist because it is fundamental to supporting the safety net, which means it is fundamental to keeping the American population as healthy and productive and able to learn as is possible. You defund the safety net in a country where you still have millions, was it 20 million uninsured, 16 million
Right.
uninsured?
Right.
You have millions of other individuals who have insurance, but their deductible is so high that there's a real disincentive to get any care until it's a crisis, and of course, that means they're in worse shape then. You defund the safety net. You make it harder or impossible for people to get the services they need. You pay for that not only right now in terms of economic ability, but you pay for it for generations in terms of children's ability to learn, in terms of families' financial and social stability. And a lot of our patients at health centers are patients who are challenged by a lot of social determinants, factors that have to do with their health that aren't directly health related, whether it's, lack of stable housing, food insecurity, etc. And to your second part of your question, the real beauty of the 340B program is that I can't say that it is 100% cost free to the federal government, but it is darn close. Okay. What this program does is say, hey, manufacturers, you need to cut a break to these safety net providers. So it's so there's no direct outlays for this program other than a couple dozen staff outside of Washington, D.C. who oversee the program. That's why I said, like, it's not 100% free, but it is so incredibly low cost because the cost is not something that it's just not on the federal government's books, other than for the 27 staff in Bethesda or Rockville, Maryland.
Do you think the 340B is going to go away, Colleen?
Not on the watch of people like you. It can't. I think it could be really seriously weakened, but I really hope it doesn't get to that point, because let me tell you, if it is really seriously weakened, we are going to see the consequences in terms of health access and health status and other areas of federal spending for people who aren't healthy. And I think if it gets to the point where we have to start seeing those consequences, then Congress will act to protect the program, because we need Congress to act. I really hope, though, that it doesn't have to get to that point, that they don't have to see the consequences of so much that is to be lost if this program is not protected. Because the services that are going to be lost it's not a light switch. It's not something you can turn off today because the program's under attack and suddenly you shut down your dental clinic. And then next week, the program's protected. It's not something you can just set right back up. I was talking to a health center up in New England who recently had to shut down their 2-chair dental operatory in one of their clinics because of the loss of 340B savings, because of some of the attacks the program is under. And they said to me, it's not just it's not just right now. They said, we struggled so hard to find dentists to come to this rural area. And to find and dental assistants. And what chances do you think it is that anybody's going to come back and want to work for us again after this?
Yeah.
So I really hope that Congress realizes how much the safety net and the society as a whole stands to lose if this program is not protected, before we have to actually see the repercussions.
Mm-hmm. Colleen, do you have any suggestions to our listeners out there on what they can do to help spread the word?
Yes, absolutely. This program is under attack from many different angles that we didn't have time to get into today. But let's just say that health centers are seeing the savings that they rely on shrink very noticeably, very, very noticeably because of these attacks. every time you talk to somebody in Congress about it, because Congress is really the only ones who can comprehensively fix the problems, okay? Every time you talk to somebody in Congress about it, they say, oh, we know that health centers, you're doing the right thing by this program. You're good actors. You're reinvesting the savings in underserved communities. We don't want you to get hurt. To which I say, I so appreciate your good intentions, but the reality is we are getting hurt. And it's not just the health centers as organizations, it's the patients. It's the underserved patients who can't get the dental services, are no longer getting the behavioral health services, are no longer getting services in schools, etc. The number one thing you can do is reach out to your member of Congress, and you don't need to get into a whole lot of details. Don't worry about the details, but say the 340B program is essential to the stability of the primary care safety net. It is under threat from many different directions, and therefore patients' well-being is under threat. And Congress, we need you to act. Those are the 3 points. The incredible importance of the program, the fact that the threats are real and larger and patients are getting hurt, and Congress, we need you to act. Congress needs to hear from us. It's a complicated, messy program. Everyone would just prefer that it goes away up there, I feel like. It's not going to go away. So that's the number one thing people can do is just reach out to that with that simple message to your member of Congress over and over again so that they know they have to act to protect the safety net patients.
Wow. You know, I sit there and I think about this as I'm listening to you. You know, if people can't get access to their insulin, their hypertensive drugs, even those who are, who struggle with addiction, and these folks have jobs, they're hardworking people. And if they can't get their medications, right, through these community health center programs, then that means they can't go to work. Right? That's not where we want people to be.
I mean, what I say about, primary health care so clearly, even if you leave the ethical concerns about whether or not you feel that people have a right to health care aside, my background is in economics. It just makes economic sense to keep people healthy, to keep them on their medications, to catch them when they're mildly sick and take care of them then, rather than wait. It is so penny wise and pound foolish to not protect this program now, because we will so live to regret it, because we will have such a bigger mess to clean up later if Congress doesn't act now.
When I look at the number of people that the community health centers in the state of Virginia saw in 2021, and you can most likely predict that a very high percentage of those individuals are on prescriptions, right? Are taking medications to keep themselves healthy and disease-free. To have all those individuals to not be able to access the schools, to go to school, to go to work, to go and buy food for their family because they're too sick to do it. Like you said, it will be a big mess if we cannot lift up this program.
And my hope is that Congress will see the light and act on this before we have the mess, because it's certainly a lot easier to keep a system that is working very well, running very well, than to let it fall apart, let the clinics close, let the services be shut down, and then have to pick up the pieces.
Yes.
I mean, just purely from an economic standpoint, it makes sense to deal with this program now.
Absolutely. Colleen, I think I say this all the time, and you hear this from me all the time. Thank you.
Oh, thank you.
Thank you for your expertise, your education. I can't tell you enough how much I love to just sit here and listen to her when she talks, because she truly is a wealth of knowledge. And with that, listeners, just know Colleen will probably be back, maybe not for 340B, but we'll be back for some other topics. So Colleen, thank you for your time. And we really look forward to having you back, and keep up the fight.
Absolutely. You too. Thank you for everything you do to keep Virginia healthy.
I want to thank my guests for joining us today. And thank you to all the listeners for tuning in to Common Health, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support Common Health, I encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org. This is Tracy Douglas. Thanks again, and I'll see you next time.